Hey everyone, welcome back to Ace the AMC. Today we have an AMC style question from our partners at Ace the Exam. It's a very important cardiology question, one which I've seen have popped up on different AMC recalls, and I've also seen it in the AMC handbook of MCQ questions. So let's get into it. We have a 60-year-old guy who comes into the emergency department with a complaint of chest pain and lightheadedness. He basically had some angina and then it began radiating to the shoulders. It was not relieved with GTN spray. He's hypotensive, he's bradycardic, and his refs are 20. He has bilateral basal lung crackles, and his ECG shows ST elevations and leads 2-3 in AVF. So what's the most appropriate next step in management of this patient? So first of all, we need to realize what the ECG is showing. So this is an ST elevation and 2-3 in AVF, which means we have an inferior wall MI. Okay, this is usually due to a right coronary artery occlusion. So remember that the right coronary artery supplies the AV node and the SA node. Okay, so this commonly explains why inferior MIs can cause bradycardia. So we need to quickly realize that this patient is crashing and that they are most likely in cardiogenic shock. And this is because the heart rate is low at 30, not because his heart is weak. Okay, so remembering that cardiac output is equal to heart rate multiplied by stroke volume. And then we also want to think about mean arterial pressure, which is cardiac output multiplied by total peripheral resistance. So those are kind of two formulas I always have in my head whenever I'm presented with a cardiology type question. So if our heart rate is low, our cardiac output will be low, and therefore our mean arterial pressure will also be low. So he was given GTN spray in the ambulance. This may have made him worse. Remember that GTN causes venodilation, which reduces preload. And when we're thinking about inferior and right ventricular MIs, they are preload dependent. So when the preload drops, right ventricular filling falls, left ventricular output falls, and the blood pressure will drop even further. This is why nitrates are contraindicated in people with an inferior wall MI, with hypertension and bradycardia. So let's go through the answer options here. So we have intravenous normal saline. This is incorrect because fluids will increase preload, but they do not fix the heart rate. So the main problem here is the heart rate. This patient already has pulmonary edema, so fluids may even worsen lung congestion without improving the cardiac output. So that's incorrect. A GTN infusion. So this is also incorrect because, as we just said, GTN further reduces preload and blood pressure. This patient's already hypertensive, okay, so this could worsen the cardiogenic shock. Intravenous epinephrine. This is incorrect because epinephrine, remember, stimulates beta-1 and alpha-1 receptors. Okay, this will increase the heart rate, the contractility, and the afterload, but it also massively raises myocardial oxygen demand. Okay, this is something we don't want in this case. He's having an active MI, which means this can worsen the ischemia and increase the infarct size. So epinephrine is actually second line to the medication we are going to give to this person. Our next is intravenous dobutamine. This is incorrect because dobutamine, remember, is a beta-1, acts on beta-1 receptors. This increases contractility but doesn't increase the heart rate. So this patient doesn't have a pump failure, it has a rate failure. So he's in severe bradycardia. So this will not address the primary problem. And our correct answer here is intravenous atropine. Okay, remember atropine is a muscarinic receptor antagonist. It will block vagal or parasympathetic tone to the SA and AV nodes, which will allow the heart rate to increase. An inferior wall MI often causes vagally mediated bradycardia, and atropine will kind of directly reverse that. It'll do it by increasing the heart rate, the cardiac output will improve, the mean arterial pressure will improve. So remember some key teaching points here is that bradycardia is often common in inferior wall MIs. Hypertension is often heart rate driven, so you want to treat the heart rate first, okay? So click submit there. You can see a great explanation there. As always, they'll have the references in there as well. So I just wanted to make another note that it's really important in AMC to not know every single ECG out there. There's only going to be very uncommon or common ECGs within AMC. They're not going to test your knowledge of electrophysiology or super rare channelopathies, or they're not going to test axis deviation. Okay, they're going to look at STEMIs, NSTEMIs, unstable angina. They're going to look at bradyarrhythmias like sinus bradycardia. They're going to look at AV blocks. They'll look at tachyarrhythmias like atrial fibrillation, supraventricular tachycardia. They'll look at ventricular and tachycardia and fibrillation. They'll also look at electrolyte abnormalities, okay, so hyperkalemia, hypocalcemia. They'll look at ECG syndromes, so left ventricular hypertrophy, bundle branch blocks, maybe pulmonary embolism. And they'll also look at drug-induced changes, so things like what antiarrhythmics, antipsychotics, digoxin, things like that, what that can do. So it's important to not be a cardiologist when it comes to these questions. It's important to recognize what the ECG shows and then the next best management option from that. So if you like this video, please leave a thumbs up and let us know if you'd like to see anything else. We'll see you in the next one.